Alrighty. Hello, everybody, and welcome to the University of Washington Department of Medicine Grand Rounds. My name is Shiv Bhandari, and I'm a chief resident at the inpatient side at our Montlake Hospital. I'm excited to introduce our speaker today, Dr. Joel Kaufman. Briefly, Dr. Kaufman, he is a physician epidemiologist, board certified in internal medicine and occupational and environmental medicine. He's been a full-time faculty member at UW since 1997, holding appointments in the departments of environmental and occupational health sciences, general internal medicine, and epidemiology. He's an attending physician in the UW Medical Center Roosevelt General Internal Medicine Clinic, where he maintains a primary care practice, and also serves as the director of the UW Center for Exposures, Diseases, Genomics, and Environment. In 2019, Dr. Kaufman was named editor-in-chief of Environmental Health Perspectives, a leading environmental health journal published by the NIH. He is an elected member of the U.S. National Academy of Medicine. He is a fellow of the American College of Physicians, the American Heart Association, and American College of Occupational and Environmental Medicine. Dr. Kaufman's work integrates epidemiology, exposure sciences, toxicology, and clinical medicine. His current research activities are primarily focused on environmental factors in chronic diseases. He is the principal investigator of a major epidemiological prospective cohort study of air pollution and cardiovascular disease, also known as the Multi-Ethnic Study of Atherosclerosis and Air Pollution, or MESA-AIR. He also directs the UW Northlake Controlled Exposure Facility, a facility customized for experimental inhalation toxicology studies on health effects of combustion products, including diesel exhaust. He's the author of more than 300 peer-reviewed articles, including articles in the New England Journal of Medicine, The Lancet, and JAMA. And so, without further ado, I'd like to turn it over to Dr. Joel Kaufman and just put a quick reminder that any questions that the audience has, please feel free to type it into the chat and I'll announce them at the end. All right, and Dr. Kaufman, on to you.
Okay, thank you, Shiv. Thank you for that nice introduction, and it's my pleasure to talk to Grand Rounds today. It's been quite a few, I think 8 years since I last spoke at Grand Rounds, and so it's nice to come back and talk again, albeit in this Zoom setting where we can't have a in-person conversation, but it's nice to speak anyway and talk about both some of the work that we've done as well as some of the important issues that people are interested in. And when I was asked by the chief resident last year if I could do it this year, we talked about some of the things that he thought people would be interested in. And so we're trying to incorporate some of those topics like wildfires and gas stoves and climate change into this talk. I am most of my research has been around environmental exposures and chronic diseases with a focus on air pollution and cardiovascular disease. So of course that permeates a lot of my thinking about this, but try to speak a little more broadly and answer questions as I can. I don't have any relevant disclosures. My work has largely been funded by the U.S. Environmental Protection Agency and the U.S. National Institutes of Health. So I think I always like to stress that the work that we do is focused on environmental factors which are for non-communicable diseases, not what we as physicians and internists are focus on in terms of risk factors, because we're focused on individual level factors and how to control them. We often focus on chronic, the hypertension, lipids, smoking, diabetes, lifestyle, and diet. But for non-communicable diseases, while those individual factors are all important and all need to be addressed, there's an increased understanding that a degree of risk is conferred by risk factors that have to be controlled at a community or larger levels. And of course, this is a lot of the interest of public health researchers, but I would argue needs to be a focus for clinicians as well, understanding both social and environmental determinants of health. there's a construct which has become increasingly used in some circles of the exposome. I personally believe that this term mostly came up because of a envy of genomics community among environmental health researchers. But the construct is that only a small amount of the difference in disease risk is generally heritable for most of our complex chronic diseases that we spend most of our time trying to manage in adults and as they age. And that indeed there is this whole other world of environmental factors that are the drivers of the occurrence of disease. Francis Collin used to like to quote George Bray with the quote that the genes load the gun and it's the environment that pulls the trigger. And the idea being that all of the things that people are exposed to in their life are the things that create their increased risk of disease. And when we talk about that, while folks in my sphere looking at sort of the physical and natural and chemical environment focus on those features, but of course the environment is really a lifelong set of things, everything from physical activity levels to infectious agents, to diet, to all those lifestyle things, but also things that like air pollution and climate, the built environment, social environment, and so forth. So they all fit into this exposome. And again, the tendency is to focus on an individual risk factor modification when so many of these agents are not really under the control of the individual. So today I'm going to sort of take a quick tour over a few topics in particular, talking about ambient air pollutants, talking about wildfire impacts, which I think has become near and dear to the heart of many of us in this area of the world over the last several years as these impacts have gotten greater and greater. Talk about the concept of environmental justice. I'm not going to talk too much about climate change and health, except as it overlaps with some of these other topics that I'm today, because you've had other opportunity to hear about that. And then get to this issue of gas stoves that I think keeps coming up and rearing its head. And I'll try to frame this in a way that makes sense for internists and practicing internal medicine specialists. So a lot of our interest in air pollution health effects really went back to a episode that occurred in 1952 in London when due to cold weather combined with air stagnation and the use of coal burning in almost everybody's individual home, apartment, a thick layer of smog encompassed the city. And this is a picture of London during the day with police directing traffic on the streets because you couldn't see more than that distance in front of you. This is a figure showing a time series of the pollution levels. In this case, what was being measured most reliably was sulfur dioxide that rose. This is weekly levels, and then the weekly mortality, the number of deaths in London by week during that year. And you see that there are these episodes of that there's this sharp increase in the levels of both SO2 and mortality rises and it falls, but it doesn't fall back to baseline for several months. And really, this points out that the effects are both acute and somewhat longer standing. And this was a great illustration of this. It appears that this episode was responsible for somewhere in the order of 4,000 to 12,000 premature deaths. And it really got people thinking about air pollution as being not just a nuisance, but really something to be worried about. So here in Seattle, you know, we often have prided ourselves on the high quality of life and the good air quality that we have, which is the case. But taken from the same picture here, we see one of those high impact wildfire days from summer. This one was 2 years ago now, and you see that we are having pollution that it looks strikingly like those days of from the London smog effect. And so it's worth people thinking about this and knowing about what the health effects are of these kinds of exposures. And certainly our patients do ask and attribute health concerns to those issues. And it's not just an issue where we're having wildfire smoke, but really around the world now, as the epidemiological data is combined with the levels of air pollution that exist, especially in rapidly industrializing countries. According to our UW's own Global Burden of Disease project at IHME, the estimates are that well over 4 million people's deaths per year can be attributed to ambient air pollution, and this is really sort of the one of the most important modifiable, hopefully modifiable risk factors for that in terms of overall impact on morbidity and mortality. And most of that is driven by the mortality impacts on adults, particularly from cardiovascular diseases and respiratory diseases. But of course, this method is mostly based on the epidemiologic studies that show the excess cardiovascular disease and respiratory disease from this. So, you know, when we think about air pollution and what it's doing, it's just worth remembering that for the most part, we're talking about a set of exposures that are inhaled, that we all breathe in lots of stuff every day, much man-made material in addition to pollutants and so forth. And while on a day-to-day basis, most people aren't being affected by acute effects of these things. Disease can develop. There are people who are particularly susceptible, people who have a higher level of exposure. And when those exposures are more toxic, people are more likely to have health effects. So in terms of research on air pollution and mortality, a lot of the work really goes back to a study that was done in the early 90s, or actually a lot of the data was collected in the 80s by a group at Harvard, measured air pollutant levels in 6 cities and followed about 8,000 subjects split among these 6 cities. And they were intending to look at effects of air pollution on lung function and so forth. But the most interesting finding was when they looked at just the overall age-adjusted mortality rates and adjusted for other major risk factors, they saw this very striking, remarkable relationship, linear relationship between the pollutant, the fine particulate levels in each of the cities and the age-adjusted mortality rates in the cities. And people didn't really, this was sort of a, you know, a very surprising finding, ended up being replicated in other cohorts. And this relationship between mortality and air pollution sort of spurred a lot of research that's gone on over the last now 30 years based on this finding and other findings that were largely, I would say, ecological in nature. And one of the things that was found that we found that has been particularly interesting has been that rather than respiratory diseases being the most prominent excess cause of death from air pollution, that we see that in fact cardiovascular diseases are a lot of what we see the excess burden in. And the study that we did in the Women's Health Initiative observational study now quite a long time ago, which was able to look at within city variation in air pollution in a crude way, as well as individual participants, individual women being followed with medical record review for the occurrence of cardiovascular disease, showed that for every 10 micrograms per cubic meter, which was about the kinds of variation that we saw between high and low exposed people in this cohort, that we saw that an increased risk overall of 24%, hazard ratio of 1.24, a 24% increased risk of any cardiovascular event in this cohort, and an even larger impact on cardiovascular mortality in this cohort. And one of the things that we found, interestingly, was that it appeared that these relationships were actually the relationships within the city, that is, the gradients between high exposed and low exposed people within a city, were as important or more important than the gradients of exposure between the cities. So that's why we found, I think, such a large effect. So this got us thinking down a long road around how it can be that air pollution can be contributing to cardiovascular disease. And a few years later, we started, there were a lot of studies where we were seeing that short-term exposure to air pollution were associated with increased cardiovascular disease risk. And we set out to see, well, can we determine if in a long-term study like this, we're actually able to look at a relationship between air pollutant exposures and the progression of atherosclerosis. So we set out on this challenge and put together a set of approaches that allowed us to understand, in a cohort called MESA, the multi-ethnic study of atherosclerosis, an NHLBI cohort study, and we received substantial resources from the EPA to add environmental information to that cohort, and that involved deploying air pollution monitors in each of these communities, developing sophisticated statistical approaches, and coming up with highly predictive spatiotemporal models that allowed us to understand air pollution concentrations right at the home of participants in the cohort. And putting that together with the fact that we had a set of 4 or 5 CT scans for coronary artery calcium over a course of a 10-year period in this cohort, we were able to look at the relationship between the rate of increase in atherosclerosis as measured by coronary artery calcium and the amount of air pollution at the residence of the individual. And this figure shows on the left one of the pollutants that we looked at, which is oxides of nitrogen, NOx, we call it, and the kinds of maps, although there would be even more dramatic variation if we were to drill down at the block by block level. But what we saw was strong relationship between progression of atherosclerosis in this cohort and particle exposure, oxides of nitrogen exposures in the cohort, as shown in the figure on the right. And these are really in the same order of magnitude as sort of the individually modifiable risk factors, the cholesterols and the blood pressure and the smoking that we think of in people. So these were quite dramatic, quite large findings, and really led us to conclude that we can conclude that there's an increased progression rate of coronary artery calcium. The relationship was seen strongly within metropolitan area, and this suggests very strongly that there's an association between air pollution and the risk of atherosclerotic cardiovascular disease. We were able to also use the same set of CT scans, actually over a 15-year period, to look at quantitative measures of emphysema in this cohort as well. And in the paper we published in JAMA more recently, we're able to show that there was an effect of an association between the change in percent emphysema on CT scan and the air pollutant concentrations. And in this case, it was particularly the ozone concentrations, which is not that surprising because ozone is a potent respiratory toxin. And And these effects were in the same order of magnitude as smoking a pack of cigarettes for about 20 years. So we're looking at a substantial level of increased progression of emphysema in this cohort in relationship to air pollution. So over the years, there's been quite an explosion of research on air pollution and all kinds of chronic diseases, as well as acute diseases. And I would say over the last several years, the focus has shifted a fair bit to the impact of air pollutants on neurodegenerative disorders. And there's particularly interest in air pollution and cognitive function and dementia and Alzheimer's disease. And we took advantage of a cohort. It was actually originally a clinical trial of ginkgo biloba, which recruited participants to a ginkgo biloba trial to see if it prevented the occurrence of dementia. It did not, but we used that data, which was an extremely well-characterized data set for the occurrence of dementia, and we were able to go back and by using a variety of creative residential history techniques, taking advantage of some proprietary residential data systems, to go back to about 1980 in the population and see if long-term exposure to air pollution going way back in time in this cohort was associated with the risk of dementia, and found that indeed, if we go back 20 years in exposure, we see a substantially increased risk of about a 20% higher risk of dementia for what we call an interquartile range, which is between the 25th and the 75th percentile of air pollution exposures in this cohort, of PM 2.5 in this case. So that's that's sort of a quick tour through some of the research that's been going on. We have a system in the United States through the U.S. Environmental Protection Agency, what we call criteria air pollutants. These are the main standards at this point in time that are adhered to, and this is a figure that shows what the standards are and why. The reason I bring this up is that it's many of you will have heard about the air quality index, and I probably will be circling back around that again. And you'll hear, oh, the level is 100, or the level is 200, or the level is 50. And those numbers are scaled to 100 being this left-hand column here, the short-term EPA standard. And every day they look at what's closest to the standard or the highest in relationship to the standard. And that level is it's not a strictly linear, but it's basically compared to that. And so if the air levels are 35 micrograms per cubic meter, they will say today the AQI is 100. Or if the ozone level is 70 parts per billion, they will say that we're at 100 AQI. And that's what those levels represent. And you'll see those numbers, and and that's when you switch to from healthy to unhealthy in the AQI that is now everybody's looking at all the time. I'm not going to spend a lot of time talking about the pathophysiology, although there's a lot of interesting and important research that's confirmed the biological plausibility of the health effects of air pollution on systemic disease. But basically, there are, for lung diseases, it's fairly clear that you can have direct injury to the pulmonary epithelium, or for some of the pollutants that go deep in, all the way to the alveoli. But for most, it's an airway impact. But for the systemic disease, this is where the story was always more complicated. And we've now found evidence of several processes that are going on, and which are most important for different diseases, aren't as clear. But the very smallest particles can translocate directly into circulation, and the very smallest particles actually will cross the blood-brain barrier and get into the brain, get into the vasculature, and cause an inflammatory response. We also know that In many cases, air pollutants will trigger autonomic system activation directly through sensory pathways that begin in the respiratory tract. And we also know that either through effects that start in the lung or in systemic circulation, you can get cycles of oxidative stress and inflammation as a result of the upstream damage from air pollution. And again, I think I've already tried to make it clear, but there are, sort of these protein health effects of air pollution that have been now characterized in virtually every system. And although our estimates of the global burden of disease are largely based on cardiovascular and to a lesser extent pulmonary effects, we also know that there are these other effects that aren't sort of solidly determined enough to contribute to those kinds of estimations, but are so now particulate matter air pollution is considered a carcinogen by the International Agency for Research on Cancer. And as I indicated, these effects on dementia are becoming more and more understood. So again, lots of people publish these interesting photos interesting cartoons, but basically the bottom line being that air pollution exposure is a risk factor for disease in multiple organ systems. So I'm going to shift gears a little bit now and talk about wildfire smoke, since we have all now been exposed quite a bit over the last several years, and through a phenomenon which is at least largely due to climate change, although there probably are some forest management practices that are involved as well. But the increasing frequency of both fires and impacts of fires across large swaths of the world, and we're certainly seeing it in the Northwest. And this last year, the Northeastern United States experienced it. And suddenly everybody got very excited about wildfire smoke because, our political centers were also being affected. But we've gotten used to being affected almost every year by wildfire smoke. And it's gotten to the point, since we have done a good job of reducing air pollution from other sources of air pollution, we've gotten to the point where wildfire smoke is actually not just contributing to these daily highs, but it actually contributes to our annual average pollution because we have so many days of so much high smoke exposures in the city that it impacts us on a calendar base, on an annual average basis, increasing the likelihood that these effects are going to be related to chronic diseases as well as acute diseases. So what is wildfire smoke? So it's actually not a perfectly straightforward question, because although we know about the smoke is largely coming from incomplete combustion of wood, so you get the cellulose, the lignin, the resin, the inorganic salts. This results in a heterogeneous mixture of particles and gases. And the gases can include a wide range of both volatile organic compounds and polycyclic aromatic hydrocarbons. But there are also primary and secondary pollutants that are formed. You can get ozone forming as a result of the VOCs and the oxides of nitrogen that are in the air. The other thing, though, however, which is of concern, is that a lot of these wildfires, by the time the smoke is finding its way to urban cores, has also involved the combustion of urban areas with a lot of man-made materials also being burned, and that means that what's in the smoke is very unpredictable and difficult to characterize. If you were to have asked me several years ago about, was it possible to do good epidemiologic research on wildfires, the answer was, it's pretty hard because most of the people who are heavily impacted live in very rural areas where the populations are so small. It's hard to see anything other than sort of very acute injuries. But over the last handful of years, of course, major urban areas have been increasingly impacted. Populations are much larger. There's every reason to think that these population health effects are getting bigger and bigger, and we're going to be able to have better epidemiologic evidence. At this point, the evidence is modest and growing that air pollution from wildfire smoke is hazardous as other air pollutants are and causes health effects that we can anticipate based on what we know about other air pollutants. The other thing that's become quite clear about wildfire smoke, I think, as you will all recognize, is that the effect of the pollution on people isn't just the physiologic response, but you also have quite a lot of psychological response. And you'll have lots of people indicating that they are depressed or anxious and more because of that. I have a bunch of slides on the chemistry. I don't think I'm going to spend very much time going through it today. But it is a concern, and we've learned quite a lot about this from studies of both firefighters initially in urban settings, but now we're having more and more research coming out on health effects in wildland firefighters, and this is proving to be quite interesting to determine that these health effects are happening, and that we are. So this some nice cartoons. But it is a challenge from a research perspective because the smoke that impacts us in an urban area or people who are many miles downwind of a fire is quite a lot different than what's close to the fire. There are a lot of variables involved, what kind of wood it is, whether it's wet or green or dry or what. And so there's a lot of variables that are involved. But I say the literature is becoming more and more clear that the health risks are not that dissimilar from other kinds of particulate matter and ozone air pollution sources. In addition to the effects of pollution, particulate matter, and the ozone, which are clearly the case during a wildfire episode. The other thing is the amount of polycyclic aromatic hydrocarbons which are sort of the key carcinogenic agent in combustion products, and are especially rich, for example, in cigarette smoke, are also there in high concentrations in wood smoke. So if you have an AQI of around 200, so that's about a particle level of roughly 70 micrograms per cubic meter of PM 2.5, that's equivalent to smoking about 3 cigarettes. So that's at least one person's calculation. So we see during the wildfire episodes, these kind of irritation effects, itchy eyes, headaches, stuffy nose, and cough. But we also see an increased risk of symptoms, particularly in people who have pre-existing lung disease, increase in respiratory infections. And then we're seeing increasing evidence that there are more heart attacks and arrhythmias and exacerbations of heart failure in the day of or several days after a wildfire episode. And the question about to the degree to which they impact on chronic health problems or have more delayed effects, I think is still a little up in the air. But I think we're increasingly concerned as they clearly add to even the levels can be high enough that they contribute to an increased annual average of air pollution levels. So what do we recommend in this case? We recommend that, first of all, that people follow the public health agency's advice, which is typically to use the air quality index to inform daily activities. There are usually recommendations that are made regarding activity. But I think the hard advice to give people is should an individual not do certain activities? Should an individual invest in air cleaners, purifiers, and filters? And should people use masks? Were I to be giving this talk 10 years ago, the idea that we could convince people that they should wear masks as a public health prevention measure seemed ludicrous on an ongoing basis in this country. But in fact, many people have gotten quite used to wearing masks to protect themselves, and a well-fitting N95, KN95 mask will protect against the particle phase of of wildfire smoke, just as it does for the other infectious hazards in our environment that people are now interested in. The real trick, I think, for internists is identifying your most at-risk patients who might be the ones who are at risk for a pulmonary exacerbation, asthmatics, COPD, any number of chronic lung diseases, people, certainly people who have had lung transplants for chronic disease, clearly at risk. And these people probably, it's worthwhile advising them to invest in an air cleaner in their home and staying indoors when they can. And that's just sound advice. Whether I would say that it's based on clinical trial grade A level data, it's another story, but I think it's sound advice. So I did notice that there was a question in the chat that came through about the interrelationship between air quality and other structural issues. I think the question had to do with income and race, but I think it's an important question. The specific question was, do we adjust for that? And the answer is yes, we're able to adjust in our cohort research for a variety of factors, including neighborhood scale, socioeconomic status, and individual socioeconomic status, as well as race and other factors. But I wanted to bring up this term of environmental justice because it's become a very hot term, and the Biden administration and the US EPA has put a very large emphasis on addressing environmental justice in a wide variety of ways. And this is the EPA's definition, although not the EPA's figure, of what environmental justice is. And the idea being that an environmental justice, and the term is often used, there's something called an environmental justice community, which is a community that on the basis of these kinds of social and economic structural inequalities is also burdened with unequal environmental risks. And that's the issue around environmental justice, is making sure that we give at least the same degree of protection from environmental and health hazards to communities who are less empowered and have more historical and structural discrimination and marginalization of those communities. So I find the term environmental justice to be compelling and also sometimes a little squishy. And I typically prefer to actually think about the term environmental racism, because I think often this is what we're talking about, is that racism, which is already conferring advantages of one group over another, and these practices which have enabled these racist structures and institutions are quite tied up with influencing the environments where people live and play and work. And so thinking about an environmental racism as a component of this system of oppression, and not, I think, as the questioner might have been saying, thinking of it as it's not just a confounder, it acts synergistically with these other impacts. We find that air pollution levels are higher in historically redlined communities. We find that, and obviously the underinvestment in infrastructure often has gone hand in hand with the siting of freeways and polluting facilities and so forth. So these cumulative impacts are quite hard to disentangle, but I think they have to be thought of that way. And since we know both that for example, Black Americans and American Indians, Alaska Natives are also more likely to die younger and underrepresented in many of the studies of chronic diseases. I think putting this all together is one of the major challenges we have in thinking about environmental health and environmental risk factors. just want to touch briefly on this question, which was asked to me about gas stoves. And I bring it up, this quote, "They can pry my gas stove from my cold, dead hands," was a quote from congressman who's been in the news for lots of reasons lately, Matt Gaetz of Florida. And he was responding as part of an anti pollution and anti-climate change initiatives of the Biden administration to say nobody's going to take away his gas stove. And so I thought it was worth talking a little bit about gas stoves and why we're talking about them and what people should think about having a gas stove or not. I know that many people like myself have been using gas stoves and like to use gas stoves because of the control it gives you in your cooking, and the fact that it turns off and gets cold quickly. But I think we're talking about them for two distinct issues, and they often get conflated. And I've found that sometimes people are talking about one thing when they really are more concerned about the other. So the two distinct issues are what's the health effects of indoor combustion, burning natural gas in your kitchen? And the other is why are we using fossil fuels that are, and having these individual combustion sources in our home, and what impact does that have on climate? And those are, I think, both important and separable to some extent. So it is clear, and there's a long course of research on the topic, that burning natural gas inside does produce pollutants. We often use oxides of nitrogen like NO2 as our kind of tracer, as our surrogate for combustion. And we can find predictably that homes that have a gas stove will have higher levels of nitrogen dioxides. And we also find that nitrogen dioxides in epidemiologic studies are associated with all kinds of health effects. And the thing we mostly are concerned about with these are respiratory hazards. So we know that for people who have asthma or chronic lung diseases, that a gas stove produces levels that are probably sometimes high enough to impact their respiratory health. We also know, and I didn't finish my thought on the slide, that these effects can be substantially reduced with effective exhaust ventilation. So a good operating ventilation system over your stove can dramatically reduce the amount of toxic air pollutants that you'll be exposed to in the home. Not to background levels, but way down and probably out of the levels in which people are usually concerned. That said, I think we are at a point now where we need to look hard at every source of fossil fuels that we're using because of their impacts on global climate change. And I think that the rationale for moving away from gas stoves for most people should be on that I'm not recommending that people throw away or claw the gas stoves out of the hands of anybody right now. But I think that as new buildings are being built and as people are replacing a stove, that they should know that there are excellent options to natural gas that exist, and even for high-end users. So if you're someone who has your expensive Viking stove, or you have your patient with their Wolf stove and they're in love with cooking with gas in that way, they should know that many chefs actually are quite happy cooking with an induction cooktop, which offers many of the same features of very quick heating and very quick cooling of the cooktop itself. So that's my little comment on that. Okay, so again, I want to circle back to this idea about thinking about how you prevent the health effects of air pollution, to recall that there are both community level and personal strategies that are important. In most cases, community level strategies will be more effective and affect more people and prevent more health effects in the long run. That said, there's still a role for some personal strategies, and many people are investigating these. Sometimes that includes modifying your activity level. Sometimes it includes a home filtration of like a home air cleaner. Sometimes it includes personal protective equipment such as masks. Some have recommended certain medications. I don't think there's any evidence basis for that at this point in time, but maybe in some situations that would be appropriate. And this is just another table that shows the kinds of things that people can do, monitoring the local air forecast. I think actually people are definitely doing this now, no question about it. Thinking about activity modification, thinking about how to clean the indoor air, thinking about masks. Each of these have upsides and downsides, and in general, individual level interventions will be less effective than community level interventions, but sometimes that's not possible, like when the cloud of smoke descends on your city. It's out of your hands, but you have to do things to protect your own health and the health of your patients. The American Heart Association has put out a policy statement about how to reduce the burden of ambient air pollutants, and this went through both policy options as well as non-policy options. But I think a major piece of this is understanding that air pollution health effects are actually going hand in hand with the production of greenhouse gases. And so thinking about the things that we need to do to reduce climate change and the production of greenhouse gases that contribute to climate change, and then the health effects of those things, which will include all kinds of impacts, including more wildfires and extreme weather events, which have their own health effects, are many of the same things that will reduce air pollution now. So I often find myself repeating the idea that the things that we do to prevent climate change aren't going to help us some now, but a lot in the future. But they will reduce air pollution now and reduce the risk of air pollution related health effects in the present. So these are called co-benefits, and the co-benefits are large. That if we can do the things which reduce the drivers of both pollution and greenhouse gases, and increase the things which are the mitigators of those impacts, we'll be helping both the planet and our individual patients. So at that point, I think I'm going to close, open it up for questions, and see if anybody has any.
Thank you so much, Dr. Kaufman, for that amazing presentation. There's a question from Dr. Michael Schwartz in the chat. The question reads, across the US, the number of days with an unhealthy AQI seems much higher in recent years owing to uncontrolled wildfires. Is it possible to estimate attributable morbidity and mortality and what we might expect moving forward? Seems like an unlikely problem to go away anytime soon.
So the answer is, well, of course, it's a very important question and a very good one. And I think that it's true that the problem is unlikely to go away anytime soon. I think it's probably going to get worse before it gets better. Hopefully through a variety of ways, we'll turn the corner on the wildfire problem, but it's not looking very good right now. And there are people working on this issue of trying to estimate the attributable morbidity and mortality from that. There's actually quite a lot of research going on in this area. It takes a few years after an event to have sort of all the data together to be able to come up with those impacts. But I think we are seeing them. And it's not just the wildfires, but it's of course the extreme heat events that we have as well. And they can go hand in hand as well. But we do see peaks of heart attacks and hospitalizations for respiratory disease following wildfires. And I think we'll get a better sense of the actual numbers on that pretty clearly in the next couple of years. There's quite a lot of groups working on trying to put those numbers together.
Thank you. There's also a comment from Dr. Dave Condiff stating, quote, "My personal belief is that the single greatest health impact of climate change comes from the fact that climate change drives conflicts over resources, migration, and wars." If you have any thoughts about that.
Well, I think that it is. I think that's may well be right. I don't know that. I don't know that we know that yet, but I think that's a very important fear that that as we get into more problems with um, droughts and we're just beginning to see the issues around migration, that these will be sidelights. I think right now, I don't know, I shouldn't probably weigh into that, but I think there's other geopolitical issues right now that are driving a lot of our conflicts on this planet. But that climate change has a big risk of being a contributor to geopolitical conflicts as time goes on.
Thank you. And one of the questions that I had was, is there any evidence that suggests that people have a capacity to acclimate to kind of worsening air pollution? For instance, if you were to compare a wave of kind of the morbidity and mortality in Seattle during one of the spikes in pollution that matched one of the more consistently polluted cities in other parts of the world, is it similar, or how does that play in?
Well, it's an interesting question. And I think this is actually a place where there's a difference probably between air pollution and heat, because we know that extreme weather events are mitigated by acclimatization, so that the people who are used to living in very hot environments can deal with a hot environment, maybe not an off the chart hot environment, but the everyday. And there's a long history of physiologic research that shows that people acclimatize to temperature. There is no such in research literature that shows that we sort of adjust to high air pollution concentrations. That's it's a little counterintuitive because of course we as a species grew up with fire, and you would have thought that we would have gotten used to it over the years. But of course, we weren't engineered to live as long as we're living now either. So there's lots of things that aren't the way that can't be explained by evolution, I think.
Thank you. And we have another question from Dr. Marcia Goldoft. Can public opinion be shifted so we reduce our collective carbon footprint, fly less, buy less, eat more vegetarian diet, etc.?
Well, that's a question for much smarter people than me to answer. I certainly hope that public opinion can be shifted, but I think we all are aware that public opinion is, in our extremely partisan environment, is being shaped by lots of misinformation, and a lot of which is being fueled by vested interests in maintaining the status quo with regard to fossil fuel combustion and carbon footprint. So as long as a lot of our information flow is impacted by the combination of misinformation and special and vested interests, I think it's going to be a challenge.
All right. I think those are all of our questions. Thank you so much, Dr. Kaufman, for your amazing and very pertinent presentation. I really appreciate the time you took to present today at Grand Rounds. Thank you, audience, for your attendance and for your participation. And we'll see you in about 2 weeks for our next Grand Rounds. Thank you, everybody.